Thank you very much, Madam Chair. Last year, the committee provided $125,000 in new funding to expand the Indians into Medicine program to an additional location for a total of 4 programs. There's been significant interest in expanding this program for many years in my home state, and we are hoping that the University of New Mexico will become the 4th location. Could you please share the status of the program expansion, and when will IHS select the location?
Thank you, Chairman Udall, and we definitely appreciate the addition of $195,000 into the 2019 budget. We expect that we will be soliciting through the competitive process the opportunity for the expansion of the InMed program to a 4th site. And I'll have to ask Ann if she knows off the top of her head when we expect that solicitation on the street.
That solicitation should be coming out pretty soon. It will announce another 5-year competitive award cycle, and that would start in the fall. So current awards continue through September of this year, August of this year.
Okay. Okay. Shifting, thank you very much for that answer. Shifting over to the community health aid program versus the community health representatives. Admiral Wiaki, I want to talk about the proposal in the budget to cut the community health representative program by nearly 2/3. 2/3 over the past year, the Congress has heard from tribes in New Mexico and across the country about their support for the CHR program. These communities rely on the CHR program to provide wraparound services like health education, case management, and transportation to medical appointments for elders and other members of tribal communities. And I understand that the administration heard the same message, yet here we are again with a budget request that proposes a significant cut to the program. I understand that you proposed a new community health aid program which would train tribal members to provide basic medical, dental, and behavioral health services. And this is a worthy goal, but it strikes me that these activities do not replace the need for community health representatives. Do you agree that the CHR program fills a needed gap in services in tribal communities, and that the CHAP program you have requested would complement rather than replace the need for community health representatives?
Thank you, Chairman Udall. I've heard from many tribal leaders in the past 2 years now about their heavy reliance on their community health representatives for not only transportation, which I think is a misnomer in Indian country that CHRs only provide transportation, but the vital services that they provide to bedridden patients, delivering medications. There's just so much that the CHRs do. I think the introduction of CHAPS is meant as a way to elevate community health workers, paraprofessionals who are extenders of physicians. That CHAP program also includes behavioral health aides and dental health aides. Many of our tribes, especially in the Pacific Northwest and in the Great Lakes area, and now down in the Southwest in Arizona, are really pushing us to advance the CHAP agenda, get a program put together, the policy, the training infrastructure, the certification processes, so that they can begin to include CHAP programming into their annual funding agreements, because they see the value when we can't recruit and retain physicians in some of our most rural and remote locations. We can train our own community health workers to fill these gaps. And so I think the proposal is really meant to be a conversation starter and to provide our tribal communities with options to be able to dedicate their resources to best meet the needs of their local communities. And we do still run into the challenge with our community health representatives of justifying workload. I've said before, I think that this is as much a data problem that can be resolved through our IT modernization, as it is a workload issue. There's no doubt that the community health worker representatives continue to work. We're just not capturing their workload in our data systems.
Boy, there's such a need out there, is what you're saying, and the CHRs are doing very good work. This new introduction, which, as you've said, serves as a conversation piece and probably is going to provide good services too. But it seems to me that they complement each other, and that the cut here to the community, the CHR program, is not one that we should be pursuing. But let me shift over here to advance appropriations. The Indian Programs Advance Appropriations Act, which I have introduced, provides budgets for the Indian Health Service and other tribal programs a year in advance, so that tribes don't have to live through the effects of another disastrous and entirely preventable government shutdown. I know that Chairman Murkowski has also been a leader on this issue for several years, and I'm hoping that the two of us can work together and with our colleagues in the House to pass legislation and ultimately get these advance appropriations included in a budget deal. Admiral Wiaki, I know that the administration doesn't have an official position on legislation, but I wanted to ask you to confirm whether you have heard the same clamor from tribes to move IHS to advance appropriations and prevent the impacts of another shutdown.
Thank you, Senator Udall, and I want to confirm that I have heard robust support for advanced appropriations from both our tribal and our urban constituents. Very specific stories of the heartbreak that occurred during the 35-day shutdown, programs having to curtail services, having to lay off staff, all of that information very recent and raw. I've also heard the comparisons to the Veterans Health Administration, where they do have advanced appropriations and where services are not interrupted when something like a government shutdown or a continuing resolution occurs, that they are saved from those types of instances impacting healthcare.
Well, I think from what you've said today, from what I've heard, from what my staff's heard, it's really clear that we need to move in the direction and pass the Indian Programs Advance Appropriations Act. This would put the Indian Health Services in a much better position when we get to another shutdown, which we hopefully don't ever get in that situation again. I wanted to ask a little bit about electronic health records. Your budget includes $25 million in new funding to begin planning for a new electronic health record system. If VA's estimates are any guide, implementing a system like this could cost billions of dollars. Does IHS have a preliminary estimate on how much a system like this will cost and how long it will take to implement?
Thank you, Senator Udall. We appreciate and have been using a lot of the work that the DOD and the Veterans Administration have done on their electronic health record modernization efforts to inform our own efforts. Mr. Mitch Thornbrew, who is our Acting Chief Information Officer, is working with the Department of Health and Human Services Chief Technology Office on a year-long health IT modernization research project, which is meant to help inform our future budget requests and the direction that the agency would like to move in. As part of our 2020 request, we're also asking for some significant changes to the structure of our budget so that we create an IT line item, and at the same time that we centralize our IT systems. As mentioned in my opening statement, we currently operate as a system with 400 separate instances of RPMS, and we'd like to change that structure to a centralized structure where an update or a change can be made once at the national level and replicated throughout the agency. So it is a significant undertaking that we have ahead of us. And I do believe that the B word, the billion word, is well in range, and we are learning from the VA's acquisition how much we should anticipate. Also want to note that we have had that team traveling out to many of our tribal communities, those who have already invested in new electronic health records like NextGen or Epic or Cerner, and pulling information from them as well on what's working, what's not, what can be improved, what they learned through their transitions. So a lot of great work, and we're hoping to save as much money as possible for the American taxpayer. But we do anticipate with the number of systems that we'll be replacing that this will be a sizable request.
And Admiral, I hope you also acknowledge that these investments, the investments we're making in technology like this, must be made without compromising increased funding for patient care.
Yes, sir, absolutely. And we look forward to working with Congress on how to ensure that remains the case.
And who will manage the acquisition and the implementation of such a massive investment? How will the service make sure that it avoids the problems that have plagued VA's transition, including lack of consistent leadership and difficulty decommissioning legacy IT systems?
I mentioned Senator Udall, our Chief Information Officer, Mr. Mitch Thornbrew, who's leading the efforts on behalf of the agency, but we are definitely not doing it in a vacuum. We have a lot of support from the department, both the Chief Information Office and the Chief Technology Office, as well as a sizable contract with an entity that includes experts, some of whom have worked within our system before and have great insight into our RPMS system. Dr. Todt oversees our informatics and information systems. Anything that you'd like to add in that regard?
I'd just like to add that we will also be looking at, and have been in communication with VA and DoD about best-of-breed governance models. We want to make sure that we've got the voice of our clinicians so we can decrease provider burden. We want to make sure that we improve the revenue cycle management, so we'll be highly engaged with our Office of Resource Access and Partnerships to make sure that we maximize the electronic records ability to bill and generate revenue that goes back into the system and provides more health care. And we'll be working with our patients to make sure that they have a voice and access for things that really are standard outside now, like electronic scheduling and access to electronic medical records, personal health records, and things that we need to advance for American Indian Alaska Native peoples.
Yeah, thank you for that answer. And you mentioned a little bit about visiting with tribes on this technology issue. What will tribal consultation on this new system look like? How will you integrate tribes who have developed their own electronic health record system and ensure that the systems are interoperable?
Thank you, Senator Udall. The Modernization Research Project team has been traveling out to multiple sites. We want to visit not only those who have already transitioned to a new system, but also those who continue to use RPMS to hear their feedback. We're in the information gathering phase. As we move forward into future phases of the transition, we will be robustly dialoguing with both our tribal stakeholders and our urban Indian organization partners about how to use the resources that we request and how to include their systems. A big focus will be on interoperability with all of the systems that are being used throughout Indian country, as well as interoperability with our VA and Department of Defense and other healthcare systems that we work with frequently. So much more consultation and urban confer to come as we move down this 7 to 10 year transition period.
Admiral Wiyaki, the tribal healthcare system serves some of the most, as you know this well, some of the most remote locations in the United States. So the service is going to face the additional challenge of implementing its health record system in areas where access to broadband is limited or even non-existent. How does IHS expect to address the lack of infrastructure as it modernizes its electronic health record system? Will this be an opportunity to help tribes improve IT infrastructure in other ways?
Thank you, Senator Udall. And broadband access has definitely been one of our major challenges and barriers. We've not been able to move forward on the use of technology like telemedicine as quickly as we would like to because of some of the limitations that we have in many areas. We did a lot of work last year discussing with the FCC and others how we can leverage resources throughout government to create greater broadband access. I do anticipate that our IT modernization is going to be broad-based and far-reaching, that we're not just focused on replacing an electronic health record system within the agency. There's so much more that's going to be captured under this umbrella in expanding broadband access, although not specifically cited recently, is probably one piece of that. Anything you'd like to add on that?
Certainly, we know that increasing broadband access lifts all ships in Native communities, because if we can get broadband access, not only for the health system, but for the educational system, that really helps with the entire community. It helps with jobs, and so broadband is a big issue for Indian country. Specific to the electronic medical record and to our health IT investment, we also have to think about the actual investment in the computer systems themselves, the servers, the monitors, the keyboards, and then all the biomedical equipment that interfaces with those systems. We want to make sure that they're safe and protect access, but at the same time, let's make technology work for us, not against us.
Yeah, the other thing that I hope all the members here at the table will be advocates for, yesterday they had a meeting at the White House. They talked about a infrastructure package of $2 trillion. And I think it's really important, if we start moving down that road, which I think there's a lot of bipartisan support, that all of you weigh in and let them know that part of that package ought to have to do with Indian country, the things we've been talking about, and making sure that there are the kind of needs that we know that are there, that are fulfilled in Indian country with a significant infrastructure package. Now, talking a little bit about recruitment and retention incentives, last year this subcommittee was able to increase funding for the Indian Health Professions Program by $8 million for a total of $57 million. How many additional providers were able to receive assistance because of this increase, and how will this increase impact your ability to recruit?
Thank you, Senator Udall. And I'm going to ask Ms. Church to provide us the specific numbers. I do know it was a sizable increase in the number of awards that we were able to make. She's probably got the numbers off the top of her head here.
For 2019, we greatly appreciate that increase of funds. We anticipate that will give an additional 170 loan repayment awards during this year. We've also been working on our scholarships in addition, so we expect some additional awards there.
Great, thank you. And I'd like to know more about how the service plans to allocate the $8 million proposed in the budget for recruitment and retention incentives. How many providers would receive increased incentives as a result of these funds? What types of providers would you recruit most aggressively, and which geographic areas would you expect to see the most impact from these funds?
With the $8 million that's proposed in the 2020 budget, we were envisioning a very flexible ability to focus on recruitment and retention efforts. So that includes some funds for housing subsidies, if we were to gain authority for the Title 38, but then also the scholarship and loan repayment. And then in addition to those funds, to increase awards there with the tax exemption, that would enable us to save about $7 million. So with those two investments combined, we think we could make over 160 additional awards, likely much more than that if those resources were provided.
Great. Admiral Wiyaki, go ahead.
Thank you, Senator Udall. I just wanted to add on the second part of your question there, where we would focus those resources. And we have heard in consultation with tribes an interest in expanding our scholarships and loans to other professions to include hospital administrators, CEOs up in Alaska as a strategy to advance alternative pain management. We've heard requests to include chiropractors and acupuncturists as a few examples of additional professions that tribal leaders would like to see us expand those programs for.
Yeah, good. Talking about equipment now, Admiral Wiyaki, I was pleased to see your budget include a very modest increase to the equipment replacement program rather than a reduction. That said, we all know that IHS facilities are facing increasing outdated medical and diagnostic equipment, and the agency needs a more aggressive funding level to keep pace with actual needs on the ground. Could you please estimate what the annual equipment replacement needs are at IHS facilities and talk about the problems that facilities face in providing adequate care given their existing resources?
Thank you, Senator Udall. And Dr. Tote reminds me all the time, let's talk patient impacts first. And the impacts to our patients when we don't have access to the latest and greatest medical technology is that we have delayed diagnoses, we have delayed care. When new students are being trained using the most recent technology and then come to our facilities, and it's a step back for them. And so sometimes we lose recruitments as a result of not having the latest and greatest. I'll ask Dr. Tote, anything else you want to add on the clinical aspects? And then Admiral Hartz has the numbers in terms of our equipment replacement schedules and the needs there.
Admiral Tote.
Thank you, Senator. So certainly equipment like mammography units and ultrasound units that impact women's health and impact pregnancy evaluation and reduce maternal morbidity and mortality by having those diagnostics are extremely important. Making sure that we've got access to modern CT scanners and MRIs to assist with cancer diagnoses. Cancer continues to be the #2 killer of American Indians and Alaska Natives, second only to heart disease. Making sure that we've got nurse call systems, central monitoring systems, ER crash carts. I could go on, but obviously the impacts are that we're not able to diagnose things as accurately or as quickly. There could be delay in care and delay in providing those services when we don't have that equipment. And then, as Admiral Wiyaki mentioned, the recruitment and retention aspect. When you're recruiting a new doctor and you take them on a tour of the facility, they're looking around to see what they're going to have to work with. And while we know our providers are mission focused and they're dedicated and they're out there doing the best they can, they tell me every day that they need to have better equipment to take better care of our patients.
Great. Admiral Hartz.
Thank you, sir. As they've already talked about the medical impact, there's even some specific examples of what a difference it makes to have equipment come in. Recently, in the Crow Agency Service Unit in Billings, Montana, they replaced all 12 operatories there in the dental suite. New chairs, new delivery units, new lighting, et cetera. That existing equipment was 22 years old and well past its life expectancy to be used as operatories. With the requirements in 2015, if you have old radiology equipment, that you're going to get reimbursed at a lower rate if you don't have that changed. And currently it's 7%. If it's not replaced by 2023, it's going to drop to 10% on the reimbursement rates. So not only does it affect the actual care and our ability to give quality health care, but it reduces even potentially the resources we would get to do more. So we've looked at the numbers. I mean, and this is across not just federal, but also the Indian country operated facilities under self-determination. You know, from a surge standpoint, we're looking at $100 to $150 million. And then on a recurring basis, we're probably in that range of 50 to 70 million. But as we've talked about our aged facilities, we have aged equipment. And to get new technology in there, you know, we've got to get the technology that, you know, that's in here. And that's expensive technology. It's not just the broadband, it's not just all of that to get going, but it's the basics of the guts of this. And we have to have security to deal with all this medical equipment. So we're talking big bucks and then, you know, and then the recurring effort that needs to sustain that.
You know, Admiral Wiyaki, did you have anything else to add there? The points you make on the 150 million and then the replacement costs and everything, I mean, we are reminded here of this responsibility to provide health care to Native Americans. And it seems to me that, and I know you can't get into, we have a budget before us, but I think it's very important that all of you advocate up the process and make sure everybody knows that we don't have the kind of equipment to take care of the needs that are out there. And I'm not going to ask an additional question on that. The chairman is back, and so I'm going to yield back to her. Thank you very much for your testimony today. Really appreciate all your hard work on behalf of Native Americans.